Hello, differential diagnosis students and team. Our next lecture in differential diagnosis will be about hematology section and the screening for hematological disorders. So I thought that before we go to the lecture this week, we need to speak a little bit about what is normal for blood counts and so on. And before we go for diseases, disorders, and so on. So this is what I am doing today. I will be talking briefly about the pathophysiology and physiology for blood, and also at the same time I'll be talking about what are the APTA or American Physical Therapy Association guidelines for regarding hematological and coagulation numbers and disorders. And at the same time, I will be talking about what is meant by CBC or complete blood pictures, and what are the different components for this screening. So let's start together and see. So first of all, why we are looking at hematology? We are physical therapists. Oh, this is not part of our work. We are dealing mainly with musculoskeletal disorders, neurological disorders. No, you are dealing with human being. You are dealing with a patient. So the patient might have another disorder in another body system which is affecting his or her performance in physical therapy. And this is what we are talking about today. Okay, so as a diagnostic value, understanding an individual's blood status can be of great diagnostic value. When you are looking at patient's report and you see that the patient has had already some investigation and blood work, you need to understand what are these numbers, what are these components. Blood disorders rehabilitation. The oxygen carrying capacity of blood can impact client's ability to exercise and participate fully during rehabilitation. If the patient, oxygen saturation or, partial pressure of oxygen in arterial blood is low, the patient might feel fatigued, the patient might feel dizzy, the patient might not be able to participate in exercise with full capacity. Blood disorders, some patients, they might have anemias. And what are anemias? And patient might ask you, what is anemia? And you need to explain that to the patient. So anemias compromise the oxygen carrying capacity of blood. Where is the oxygen is carried in blood? It carries on hemoglobin. So you need to understand that. Hemophilus is another disorder, blood disorder related to lack of certain clotting factors, and we will be looking briefly about the coagulation cascade, and I need you to understand that. And develop bleeding in the joints. We have superficial bleeding, which is mainly related to the disorders of platelets, and we have deep bleeding within the joints, which is related more to coagulation factors disorders. Treatments: anticoagulant treatment of deep venous thrombosis, clotting factor replacement if the patient is deficient on one of the clotting factors causing hemophilia A, which is a deficiency of factor 8, or hemophilia B, which is a deficiency of factor 9 of the coagulation cascade, and so on. So that's why we are talking about hematology today. What is the composition of our blood? Following centrifugation, blood separates into two main components: plasma and cells. Plasma and cells. Okay, so this is a blood taken out of your, artery or vein, or I'm sorry for, and they are trying to look at this blood through centrifuge. What they will find, like 58% of our blood is composed of plasma, and 42% are mainly red cells, and less than 1% is white blood cells and platelet. Okay, and so now 100%, what, 58% plasma, less than 1% white blood cells and platelets, and 42% are red blood cells. Okay, and what is that? If you take blood, and you just remove everything and you only have the red blood cell mass, this is called the hematocrit. Okay. So, what is the composition of plasma and functions of these components? Plasma is mostly water. 92% of plasma is water. Proteins like 7%, salts and gases like 1%. Okay. 60% of the total plasma protein content is made of albumin. Okay, so it is very important. Albumin is a very important protein found in plasma. Albumin is involved in osmotic pressure regulation in capillaries. And osmotic pressure, we will not, deep dive into that, but, we have some sort of forces which is affecting capillary permeability of blood, and like hydrostatic pressure and plasma oncotic pressure. So, like if someone is deficient in albumin, for example, okay, and this patient might have a liver problem, you will find, like, extensive edema of the lower extremity. Why? Because when this patient lost albumin, which is a very important protein, found in plasma, the plasma oncotic pressure will be disturbed, and there will be, fluid coming out of capillaries, and then you will see this edema in the patient. Additional plasma proteins include globulins, fibrinogen, and transferrin. Transferrin, for example, is important for iron transport. So plasma, water, ions, organic molecules, trace elements, and vitamins and gases. Okay, these organic molecules such as amino acids, proteins, glucose, lipids, nitrogen waste. What are proteins types? Albumins involved in plasma colloid osmotic pressure or oncotic pressure, which is very important. Globulins like clotting factors, enzymes, antibodies, carriers. Fibrinogen is important for blood clotting, and transferrin, which is important for iron transport. Gases such as carbon dioxide and oxygen. There are three types of blood cells, and what are the function of these different blood cell types. So here we see that we have, cells. Okay, we have cells. So what are these cells? Red blood cells, which we call them erythrocytes. White blood cells, we call them leukocytes. And the platelets, we call them thrombocytes. Okay, so red blood cells transport oxygen to tissues and remove carbon dioxide waste. White blood cells, there are many subtypes of white blood cells, and what is these cells are responsible for? They regulate immune functions. Lymphocytes and mainly T cells and B cells, these are specific immune responses. We have different types of immunity, and it is, beyond our discussion today. But lymphocytes, there are T lymphocytes and B lymphocytes. Monocytes and neutrophils are phagocytic cells. Monocytes become tissue macrophages. Eosinophils involved in allergic reaction. Basophils become mast cells, which release histamine during tissue injury, which is responsible for the erythema and redness you see, and so on. So there are cellular elements, red blood cells, which are erythrocytes. These transport oxygen and carbon dioxide, and it has different shapes. It should be, this way, but sometimes it is like sickle, sometimes it is less concave, sometimes it is big, sometimes it is small, according to different blood disorders. White blood cells, like I said, include many types. Lymphocytes are responsible for immune responses, mainly B cells and T cells. Monocytes, which is phagocytic cells, this migrate to tissue and develop into macrophages. Neutrophils, which mainly fight bacteria. These are phagocytes. Eosinophils, which produce toxic compounds against invading pathogens. And basophils, which are tissue basophils, are also called mast cells. And as we just explained, everyone has different function. Platelets essential for blood clotting. Okay. Hematopoiesis, blood cell formation. As I just mentioned, that we have different types of blood cells. So how these cells formed in our body? Okay, hematopoiesis take place where? In bone marrow. So for patients who have bone marrow disorders or have certain types of cancer, they might have a problem with developing different types of these cells, either in quantity, either in quality, and this will result in different blood disorders. All blood cells come from a single stem cell. What is this cell? They call it pluripotent hematopoietic stem cell. Where is pluripotent hematopoietic cell? In the bone marrow. Okay, the pluripotent hematopoietic stem cell commits to specific fates or lineage. This is our lineage of production, giving rise to distinct mature blood cells in circulation. So, this is the main one, and from this main one, another cell uncommitted stem cells. Okay, and from uncommitted stem cells, we will have different lineage going on, different stages of maturation of these cells. So like the lymphocyte stem cell will result in development of lymphocytes. Okay, and the other types will lead to formation of eosinophils, basophils, monocytes, neutrophils. Megakeratocyte, for example, will result in development of platelets. Erythroblast will give reticulocyte, and then the erythrocyte, which is a mature red blood cells. So there are specific programs for the development of distinct cell types. So we have lymphoid lineage and leukomoid lineage. Okay. Let's go next. What maturation of blood cells in the bone marrow? Okay, mature blood cells squeeze through the endothelium. And what is the endothelium? This is the inner lining of our blood vessels to reach the circulation. During hematopoiesis, cells go through different developmental stages, migrate through bone marrow, stroma, and enter the venous sinusoids as mature cells. Red blood cells lose their nuclei during development. So mature red blood cell has no nuclei. Okay. Mature cells enter circulation by squeezing between endothelial cells. Erythropoietin, colony stimulating factor, and thrombopoietin are cytokines that regulate maturation of RBCs, red blood cells, white blood cells, and thrombocytes, respectively. So, mainly erythropoietin is responsible for the maturation of red blood cells. Colony stimulating factors white blood cells, thrombopoietin thrombocytes. So here, like in this, you can see platelets, megakeratocytes, which is responsible for the development of platelets, stem cells, white blood cell maturation through different stages. You know, this is a bloodstream, venous sinusoids, and these are the red blood cell different stages for maturation, and so on. Any patient who goes to the hospital for any checkup or anything like that, usually the first thing the physician orders is CBC, or complete blood picture. So CBC is a blood panel that provides information about the status of an individual's blood. CBC, or complete blood picture, values are compared to normal standard range typically found in males and females. Like we talked, last time. If I don't know the normal heart rate for in adults, and I'm checking the heart rate for my patient, I will not be normal if this is high or low because I don't know the normal value. The same thing. There are normal values for males and females, and we should look at the chart so we can understand if this patient is deficient in one of blood components, or there is high percentage of that component, and each one of them will signal that the patient might have a problem or blood disorder. Abnormal CBC values may indicate the potential for disease, including anemia, infection, allergy, and cancer. Normal CBC, or complete blood picture, values for RBCs, or red blood cells. As I said, that red blood cell is a huge or a main component of our blood. It constitutes about 42%. So we have the red blood cell count, the hematocrit, hemoglobin is of diagnostic importance. Okay, so what is the percentage of hematocrit? Percentage of total blood volume, which is occupied by bagged RBCs. Like if you take off or take out any other component except red blood cell mass, okay, and this red blood cell mass is the hematocrit. What is the percentage of this, within our blood? So for males, this percentage should be between 40 to 54%. And for females, the normal values should be between 37% to 47%. Why? Males have more hematocrit percentage than females, because males have higher testosterone level compared to females. Hemoglobin, and the hemoglobin, that carry oxygen, so reflects the oxygen carrying capacity of red blood cells. For males, it should be like 14 to 17 gram of hemoglobin per deciliter, and for females it should be 12 to 16 gram of hemoglobin per deciliter. Okay, and what is the red blood cell count, or the cell number of cells per microliter? So it is like that, 4.5 to 6.5 times 10, and 3.9 to 5.6, and so on. Okay, so what is the hematocrit? What is the clinical significance of high hematocrit and low hematocrit value? Okay. Erythrocytes, which are red blood cells, we measure the red blood cell count. Okay, decrease in red blood cell count could be associated or be seen in cases of blood loss, dietary insufficiency, somebody who is a vegetarian or strict vegetarian, does not eat meat, liver, and so on for a long time, or have any type of nutritional deficiency and vitamin deficiency. Somebody who is taking chemotherapy, somebody has cancer and taking chemotherapy. And you know, chemotherapy does not differentiate between normal and abnormal cells, so it might destroy the red blood cells, normal red blood cells, and this could result in a low red blood cell count. And as I said before, is 42%. This is the average for red blood cell count within our blood. This is decrease. What if we have increased red blood cell? This could be in a case called polycythemia vera, and we will talk about that later on. Polycythemia vera is a rare blood cancer that results in increased red blood cells, increased blood viscosity as a result, and might result in a blood clot. Okay. Why? This could be due to increased, erythrocytosis, polycythemia, severe dehydration, burns, or core pulmonale. What is core pulmonale? Core pulmonale is alteration in the structure like hypertrophy or dilation and function of the right ventricle, right side of the heart, mainly right ventricle, caused by a primary disorder of respiratory system resulting in pulmonary hypertension. We know that the right side of the heart is working on a lower pressure than the left side of the heart. So if you see increase in the pressure within the right side of the heart, mainly the right ventricle and the pulmonary artery, this case is called core pulmonale, and it is due to disorder in the respiratory system or the lung. So polycythemia vera, dehydration, somebody who is really dehydrated, and we know that water is one of the component of our plasma. So if you are really dehydrated, what will result? That you will have an increase in the percentage of red blood cell in relation to the whole blood. You lost a lot of water fluids, okay, and you are dehydrated. What will happen? Okay, you will have increased percentage of this red blood cell mass, and this will result in increased hematocrit. Severe diarrhea, the same, you are losing fluid. Pulmonary fibrosis, high altitude, somebody, went to on a mountain, and there are some adaptation which happens for, people, especially in the 72 hours when they move to a high altitude above the sea level. Chronic heart disease, blood doping. Okay. Hematocrit is a percentage of total blood volume occupied by packed RBCs. It could all decrease in case of anemia caused by blood loss, like somebody have bleeding within the gastrointestinal tract, like somebody who has a peptic ulcer, and this or any other disorder which might cause GI bleeding. Low iron, somebody is deficient in iron, does not eat, right. Folate, which is vitamin B9, or vitamin B12, which is a cobalamin deficiency. Leukemia, some types of, as I said, we have two lineage during the development of cells, lymphoid lineage and leukemoid lineage. So leukemia is a blood cancer which is affecting, the leukemoid lineage. Hyperthyroidism, someone who has high, thyroid function, T3 and T4. Cirrhosis, which is fibrosis of the liver. Hemolytic reactions, somebody, they transfuse blood to a patient, and there is no match. So the patient should not have this blood group. We have, different types of blood. Some people, they have A, B, A, B, O, and so on. Chemical and drugs prosthetic heart valve. If somebody, has a problem with one of the heart valves, how many valves we have in our heart? Four: mitral, tricuspid, atrial, and pulmonic valve. If somebody, for any disorder within the heart, they have changed this valve. Okay, and the artificial one is not the same like like the normal one, so it might result in destruction of RBCs and low number of RBCs and anemia as well. So hemoglobin measures O2 carrying capacity. Okay, it can be decreased like hemoglobinopathy, some abnormal blood disorders like sickle cell disease. We the red blood cell should be rounded like that. Like I'm not very good at drawing, but I will try. So like this, okay. But how about if you see the red blood cell like this? This is like a sickled cell, which is associated with high probability of thrombosis and blood coagulation, and it is one of the blood disorders. Pregnancy, it is a physiological condition, but it can lead to low hemoglobin as well. Hyperthyroidism, cirrhosis, severe hemorrhage, severe burns, systemic disease like Hodgkin lymphoma, Hodgkin disease, leukemia, types of cancer, lymphoma, another type of cancer, SLE, systemic lupus erythematosus, another blood disorder, sarcoidosis, systematic disease. So SLE is a systematic lupus erythematosus. Okay, when this hemoglobin can be high or increased, patients who go to high or people go to high altitude above the sea level, patient with chronic obstructive pulmonary disease, patients with congestive heart failure, patient who is dehydrated, patient who have polycythemia vera. What are the characteristics of RBCs or red blood cells? Normal RBCs have a biconcave disc shape, okay, like this, biconcave disc shape, to accommodate hemoglobin, and flexible cytoskeleton. Why? So it can traverse through the capillaries. Otherwise, it will be destroyed. Changes in the normal red blood cells shape or size, like sometimes it results in spherocytosis, which is more rounded shape of the RBCs, not like the biconcave shape. Microcytes, like the size of the red blood cell is smaller than normal, or sickled, like this one, indicate certain pathologies. This is a cytoskeleton of and the attachment of protein and so on. Sickle cell disease reduces the ability of hemoglobin to carry oxygen and can lead to anemia, swelling, and bleeding as well in the joints, which is deep bleeding, and painful episodes. Hemoglobin and bilirubin. Hemoglobin synthesis requires dietary iron. So hemoglobin is heme and globin, okay? And heme is iron, okay? So if you are not eating or taking enough iron, this would be a problem. So transferrin carries iron to the bone marrow, and when you will look at blood investigations or lab work, you will see this value, transferrin. That's why we are talking about. Transferrin carries iron, so it is iron carrier to the bone marrow and incorporates it to hemoglobin. Okay, so this is heme group, and these are globin. Globin are proteins. Hemoglobin contains 4 globin chains, each centered around a heme group. So, what is the composition of hemoglobin? Heme, okay, which is in the center, and we have 4 globin chains around, 4 globin chains around the heme group called porphyrin ring. Oxygen is accommodated in the porphyrin ring. This is a porphyrin ring. This is, iron in here, and we have, globin around 4 chains of globin. The spleen destroys old red blood cells. The lifespan for normally for red blood cells is about 120 days. After that, it will be destroyed. And hemoglobin from the dying cells is converted to what? To bilirubin. Bilirubin. And bilirubin is one of the proteins found in blood. Liver disease prevents bilirubin metabolism and gives a jaundice. Jaundice, what is a jaundice? Is a yellowish discoloration of skin, sclera, and mucous membrane. And we have seen a picture for that in our last lecture when we were talking about integumentary screening. Again, so hemoglobin is heme and globin. Heme is the main unit in the center, and this is mainly iron, okay? And transferrin carry, this iron to the bone marrow for hematopoiesis and so on. And then around heme, there are 4 globin chains, alpha, beta chains. Causes of anemia. There are so many classifications of anemia and so many causes for anemia as well. Anemia is a condition in which blood has a lower than normal number of red blood cells or hemoglobin. Anemia can reduce the amount of oxygen delivered to tissue. Why? Because there is low hemoglobin, and then hemoglobin, is important for carrying oxygen. What are the symptoms of anemia? Fatigue, shortness of breath, dizziness, headaches, or an irregular heartbeat, which we call it arrhythmia. Anemia can, irregular heartbeat could be also, tachycardia mainly, or bradycardia. And mainly with anemia, we will see tachycardia. Anemia can be the result of either accelerated RBC's loss, so you are losing a lot of red blood cells, or decreased RBC's production. So there is no enough production of red blood cells, or there is enough production but you lose them fast. So accelerated red blood cell loss, like what cases? Hemorrhage, and this hemorrhage could be, from skin, could be through female who have heavy menses, for example, internal bleeding, like GI bleeding, any other bleeding, hemolytic anemia, cells rupture at abnormally high rate. So there are hemolysis, and there are different types of hemolysis within the blood, intrinsic and extrinsic hemolysis, or intrinsic and extrinsic causes. Sickle cell anemia with a genetic disorders with abnormal shape for red blood cells. Acquired anemia, like in malaria, which is infection, and autoimmune reactions. So in autoimmune reactions, which are more commonly in females, the immune cells attack certain cells and destroy them, so the body attacks itself. Decreased RBC's production. Iron deficient anemia. Somebody who's have a problem with nutrition. Folic acid deficiency, vitamin B9, vitamin B12 deficiency, inadequate production of erythropoietin. Different causes might be some cases related to chronic renal failure as well. Aplastic anemia, somebody who was exposed to radiation. So what is polycythemia vera? Polycythemia is a rare blood disease where the number of red blood cells is increased. What happens to viscosity? The viscosity will be high, and and the blood flow in polycythemia will be slower. Normal, CBC values for white blood cells. The total versus differential white blood cell count indicate body's ability to fight infection, because these are the cells which are responsible for immune system. High total count can be a sign of bacterial or viral infection. A bacteria or virus invade through our body, and then there will be increase in the production of white blood cells. Why? To fight this invading organism. Rheumatoid arthritis, which is a systematic chronic inflammatory disorder or inflammation. Low white blood cell counts can be a sign of rheumatoid arthritis, cancer, chemotherapy, and or malnutrition. Neutrophil, which are a type of white blood cells mainly to fight bacteria, high neutrophil numbers are associated with infection, whereas high eosinophils count can be a sign of allergic reaction. So the total, white cell counts, the cells per microliter, is about that in males and females, and we don't have to memorize these numbers, but I'm just trying to give this lecture as introduction before we will be talking about disorders and the screening for different hematologic disorders. Differential white cell count, neutrophils should be about 50 to 70%, of the total count of white blood cell count. The same for females. Lymphocytes about 20 to 40%, and these numbers, there will be high number of neutrophils, especially with bacterial infection. Lymphocytes will increase mainly with viral infection. Monocytes or macrophages about 2 to 8%. Eosinophils about 1 to 4%. Basophils should be less than 1%. And basophils, especially for patients with chronic myeloid leukemia, which is a type of blood cancer, you will find that basophils numbers are increased. Platelets, which is responsible for blood clotting, these are the numbers. Okay. In severe rheumatoid arthritis, white blood cell count is reduced due to decreased neutrophils. Okay. So what is leukocytes? Leukocytes is another name for white blood cells. Total number of white blood cells, is important. Infections, reaction against foreign bodies and tissues will increase this number. This total white blood cell count will decrease in bone marrow suppression, because why? We said that the bone marrow is a factory where these cells are produced and then mature later on, or bone marrow failure. Patients who are on chemotherapy, because chemotherapy, as I said, kills the good and bad cells. Radiotherapy, bone marrow diseases, AIDS, alcoholism, diabetes, autoimmune disease, and some people will have lowest number of white blood cells when in early morning. When it will be increased in case of infections, inflammations, tissue necrosis, leukemia, tissue trauma, or stress, burns, thyroid storms. Thyroid storm is a sudden and very high increase in thyroid hormones, T3 and T4, and dehydration. So what is the function of thrombocytes? What is hemostasis? Hemostasis, everything in our body, we need it to be in balance. So we don't need number of cells to be much increased or markedly decreased or so on. So should be in balance. So hemostasis is a physiological process that stops bleeding at the site of an injury while maintaining blood flow elsewhere in the circulation. So we have balance. We don't need bleeding and we don't need thrombosis at the same time. The three major steps of hemostasis include if I am, if I have injury to my skin, if I have got some, cut in my skin or blood vessel, and this is I have a wound. What is the first, thing happen or reaction? Vasoconstriction. Vasoconstriction. Why? Trying to, like, if I'm having this blood vessel and I am, having this, sorry, and I'm having this cut here, and this a wound which will be bleeding. So what the thing, first thing, vasoconstriction in order to, try to reduce blood loss. Then platelet black formation, so platelets will come together into this area or opened area and will try to aggregate together in order to form a primary plug through this in order to close this opening. And then the coagulation factors or the coagulation cascade will come to strengthen this, plug which was formed by platelets in order to seal this area completely. So platelet plaque formation and vasoconstriction. So platelets, like this, I have this opening here, exposed collagen which activates plates. As I said, the first thing is vasoconstriction. So this is the endothelium. This endothelium, which is the inner lining of blood vessels, and platelets stick to the exposed collagen in damaged vessels. Sorry, activated platelets release the paracrine molecules, which are a platelet activating factor, and thromboxane A2, which reinforce vasoconstriction and attract more platelets to the area in order to, forming platelet plug. So exposed collagen activates platelets. There will be release of platelet factors. These platelet factors will attract more platelets into the area. Platelets will form a plug. This is like a primary thing, Sorry. Coagulation requires platelet and then clotting factors. Why? Because these clotting factors will seal the area, will strengthen this plug more. So coagulation relies on both platelets and specific clotting factors or enzymes. Where it is inside? In the liver. So if somebody has like liver cirrhosis or anything, there will be a problem with the development of blood clotting factors, and patient might have a problem with bleeding. These are the coagulation cascade. The coagulation cascade mainly have two arms or two pathways: intrinsic pathways, which have more factors. Okay, factor 12 lead to development, of factor 11, and factor 11 will lead to development of factor 9, and then factor 8, and so on. And this is factor 10, which is very important, and then the extrinsic pathway, which is different, factor 7, and factor 5 and factor 2, and so on. We don't need to know that, but we need to understand that we have different types of coagulation factors, and the deficiency of these Coagulation factors will result in different blood disorder, like the deficiency of factor, uh, you know, 9, for example, will lead to hemophilia A, and factor 8 deficiency will lead to hemophilia B, and so on. So, two coagulation cascade pathways convert a plug into the platelet plug into a clot. The intrinsic pathway requires a contact between exposed collagen, platelets, and clotting factor number 12. Why? So platelet factor, coagulation factor number 12 with platelets, and that will lead to activation of factor 12. The extrinsic pathway, which is a shorter pathway than the intrinsic pathway, relies on thromboplastin, which is tissue factor number 3, released from injured vascular cells, and clotting factor number 7. So tissue factor number 3, which is that, what is that? Thromboplastin. And tissue factor number 7, what is that? It is part of the extrinsic pathway. So tissue factor 3 and 7. The two pathways converge in the activation of thrombin, okay, and subsequent formation of fibrin, which is the ultimate goal for this cascade, that make up a clot. So the plug to a clot breakdown. If somebody have clotting within the blood and obstruction of blood vessel, they take some medications. They call them fibrinolysis. Lysis is destruction, is mediated by the enzyme plasmin. Conditions that cause excessive bleeding. Some people, they have bleeding, and this bleeding could be superficial within the skin, mostly due to platelet disorders, and these disorders could be increase in the platelet numbers, or abnormality related to a decrease in platelet numbers, or could be related to the formation or the structure of platelets and the activation of these platelets. And some people, they have problems related to coagulation factors, and this will result in deep bleeding, like hemoarthrosis, bleeding inside the joints. So thrombocytopenia is a very low numbers, below like 50,000 of platelets in the circulating blood. Normal blood count, 150,000 to 450. So this is a very low count. Thrombocytopenic purpura is a small, purplish blotch on the skin due to bleeding from small capillaries or venules. And what is the cause? Idiopathic. Okay. Hemophilia is X-linked disorders, abnormality or deficiency of factor 8 within the coagulation cascade. This factor will lead to hemophilia A or classic hemophilia. Deficiency of factor 9 will lead to hemophilia B, and they call it Christmas disease, another name. So platelets or thrombocytes are measure of clotting. So decreased platelets in cases of anemia, some antibiotics, people on antibiotics, pneumonia, HIV, cancer, chemotherapy, and could be increased in case of inflammation, infection, cancer, splenectomy, removal of the spleen, trauma, rheumatoid arthritis, heart disease, cirrhosis, recovery from bone marrow suppression. D-dimer. What is D-dimer? I think some of you might have heard that more, especially during COVID-19. D-dimer is a specific antigen derived from the degradation of factor 13A, cross-linked fibrin. Okay. Clinical significance of D-dimer. Increased fibrinolysis, which is a destruction of fibrin. Elevated blood concentration of D-dimer is by evidence of intravascular coagulation and thrombotic disease. Some of our patients, like I talked about in the previous lecture, about the Wells criteria for screening for DVT or deep vein thrombosis, which is blood clotting in the vein, usually the legs, and can be fatal as it can lead to pulmonary embolism. Symptoms: patient will complain about leg pain, especially around the calf muscles, calves, swelling, red and warm skin around the affected area. Okay, so patients might be need for anticoagulants. So excessive coagulation can be prevented by either inhibiting platelet adhesion or inhibiting the coagulation cascade, because we said that we have two components for homeostasis, we have platelets and coagulation factors. The body can endogenous factors that prevent the extent of clotting. Also, some medications, anticoagulants, are used clinically to treat deep venous thrombosis. So, endogenous anticoagulants: heparin, antithrombin 3, protein C, and prostacyclin. What are endogenous fibrinolysis or thrombolytic factors? Plasminogen and plasmin, and tissue plasmin activator or TPA. Let's look at lab values. What are the normal lab values, normal range, and what are the rehabilitation concentration for us? Hematocrit, percentage of RBCs within the blood. For the normal range in males should be about 43 to 49%, and females 38 to 44%. So if you see a patient, with hematocrit percentage less than 25%, no exercise. 25% to 30% light exercise. More than 30% resistive exercise can be resumed. Platelets number about 150,000 to 350,000, and some texts say 450,000. Below than 20,000, no exercise. 20,000 to 50,000, light exercise, and light resistive exercise can be resumed if the number of platelets above 50,000. Hemoglobin. The normal values could be 14.4 to 16.6 gram per deciliter in males, and 12.2 to 14.7 gram per deciliter in female. If it is below 8, no exercise. If it is between 8 to 10, light exercise. If it is higher than 10, then you can do resistive exercise. White blood cell count. It could be, normal range should be about 4,500 to 11,000 per millimeter square. If it is below 5,000, no exercise. If it is above 5,000, light exercise. Some resistive exercise as tolerated could be also resumed if the number above 5,000. But we will have we will see another guidelines for these numbers, more precise guidelines. So for blood results, sometimes you see this chart for the patient, and white blood cells, this is a total number, is 5.7. And this is a standard range, 3.4 to 11. So this is normal or abnormal? Normal. RBC is 4.33. This is normal or abnormal? This is normal. Hemoglobin. This is normal or abnormal? This is normal. Hematocrit. This is normal. Absolute neutrophils. Normal. Okay. Absolute lymphocytes. This is normal. Absolute monocytes, this is normal. Absolute eosinophils, normal. Absolute basophils, and this is normal. And you can see another chart like this, comment of the blood cells values in the patient. Is this normal or abnormal? 13.3. This is high. Is RBCs, this is normal or abnormal? This is low. Hemoglobin, this is low. Hematocrit, this is low. Mean, you know, this is usually the, about the size of the red blood cells, and should be around 80 to 100, I think, as I guess. I'm not a hematologist, but I'm trying my best. So I think this is low, and these are other values also for blood, So let's go for the next thing I want to talk to you about today. These are the American Physical Therapy Association for laboratory values interpretation. We have different sections, but mainly we will see the complete blood count. We will not spend much time on that, but I want to show you, the like white blood cells per millimeter square in a newborn should be between 9,000 to 30,000. A child be 2 years or below is about 6,200 to 17. So normal values are different between children and adults, as you can see. Children above 2 years and adult are basically have similar values, and the possible critical values is below 2,500 or above 30,000. RBCs, this is a newborn. This is 2 to 8 weeks, 2 to 6 months old, 6 months to 1 year, and then 1 year to 18 years. And these are the adult values. So as you see, which are different from children. Platelets, premature infant, about 100,000 to 300,000. Newborn, 150 to 300. Infant, child and adult, 150 to 400,000. And possible critical values below 50,000 or above 1 million. Hemoglobin values is different also for the children and adults. Older adults value are slightly decreased, like geriatric patients. Possible critical values below 5 gram per deciliter or above 20 gram per deciliter. Hematocrit, these are the percentage for newborn and different ages, and older adults value might be slightly decreased, and you see that for a pregnant woman we will have less hematocrit compared to normal values for adult males and females, and possible critical values below 15% or above 60%. So what are the typical clinical presentation with abnormal CBC values? White blood cells or leukocytes. If there is increase in white blood cells, like leukocytosis, there will be increase, in temperature, fever, fatigue, bleeding, bruising, frequent infections. What if we have, leukopenia or reduced number of white blood cells, frequent and or persistent infections, inflammations or ulcers in around the mouth, headache, stiff neck, sore throat, night sweats. Platelets, which are thrombocytes, a reduced number of increased number of platelets, like thrombocytosis. There might be headache, dizziness, weakness, chest pain, tingling in hands and feet. reduced number of platelets, thrombocytopenia, petechiae, ecchymosis, which are superficial bleeding in skin, oral bleeding, hematuria, and epistaxis. Hematuria is a blood within the urine, and epistaxis is bleeding from the nose. RBCs, erythrocytes, increase in the number of RBCs, might be weakness, fatigue, headache, lightheadedness, dyspnea, decrease in the number of RBCs, orthostatic hypotension, weakness, fatigue, dyspnea on exertion, pallor, dizziness, chest pain, leg cramps with exercise. Hemoglobin. Increased hemoglobin, there might be fatigue, headache, dizziness, visual changes, transient ischemic attack, which is very dangerous because the patient is susceptible to have a stroke. If transient ischemic attack is ischemia which happens to the brain tissue for more than 1 second and less than 24 hours, but usually it does not result in damage. Dysrhythmia of the heart beats, bruising, bleeding, additional pediatric concentration in pediatrics and newborns, like jitteriness, cyanosis, hypotonia, and respiratory distress. How about if the hemoglobin is low? There might be pallor, tachycardia, orthostatic hypotension, dysrhythmia, impaired endurance and activity tolerance, and additional pediatric consideration. Infant may present with lethargy and poor feeding. Hematocrit. Hematocrit, if the hematocrit percentage is high, might be fatigue, headache, dizziness, visual changes, transient ischemic attack, dysrhythmia, bruising, and bleeding. How about if the hematocrit is low? Might be orthostatic hypotension, dizziness, headache, pallor, cold hands and feet, angina, which is chest pain, dysrhythmia, and dyspnea, shortness of breath. So what are the implications for us as physical therapists? For patients with increase in the number of white blood cells, like what we call leukocytosis, closely assess and monitor for signs and symptoms of multi-system complication in patients presenting with hyperleukocytosis, like white blood cells over 100,000 per millimeter square, as these patients are at increased risk for cardiac, pulmonary, renal, and neurologic involvement as it relates to leukocytosis. Consider the timing of physical therapy session due to early morning low level and late afternoon high peak, as I just explained in one of these slides. For patients with a trending decrease in number of white blood cells or leukopenia, refer to facility guidelines for neutropenic precautions, as it is different from one facility to another, and adjust therapeutic activities accordingly, or the contact with your patients. Monitor for signs and symptoms of infection during physical therapy intervention, monitor for fatigue during physical therapy intervention, and educate regarding interval training, which is, when the patient can exercise, when the patient can get rest. So there are alternation between that during our intervention. And the energy conservation, consider using the Borg or rate of perceived exertion scale. I ask the patient during activity, how you feel about this activity. He said, I'm, very hard. Is just nothing, like mild or moderate, and so the patient, consider the whole level of exhaustion and fatigue, and then tell you about that on the scale from 6 to 20. Dyspnea scale, in addition to vital monitoring with activity, progression, and symptoms presentation. Provide fall prevention screening and intervention, as patients may be at risk for falls related to underlying diagnosis and treatment. Use caution during neurogenic bowel or bladder programs. See S4 and S5 testing for spinal cord injury or tumors, and rectal examination. See S4 and S5 is sacral, nerve roots, as patients may be at increased risk for infection. Notify the interprofessional team immediately if a patient with a cancer diagnosis is neutropenic, low neutrophils, and has a fever like 100.4 above 104.4 Fahrenheit or above 38 Celsius. This is considered an oncologic emergency. Oncology emergency. Discuss with the interprofessional team risk versus benefit if planning to utilize. Okay, I'm trying to give the best intervention and best benefit for my patient. How about if my intervention will cause harm to my patient? Will I go ahead or not? So I will be discussing that with interprofessional team, physician, nurse, and so on. Like, can I use dry needling? Give patients with neutropenia are at high risk for infection or not? For patients with trending increase in platelets, like thrombocytosis and thrombocythemia, screen for venous thromboembolism using patient diagnosis specific evidence-based tool due to increased risk of elevated levels. Monitor for signs and symptoms of venous thromboembolism and consider referral to a medical provider as appropriate if you see any signs of symptoms of that, because might lead to pulmonary embolism and could be fatal. Refer to a coagulation test and assay section. Collaborate with the interprofessional team regarding risk versus benefit of physical therapy intervention with abnormal finding. Somebody might have a DVT or in the lower leg, and I'm trying to do exercise for the lower leg, and all of a sudden this thrombus dislodge from the vessel wall and cause embolism, which might be fatal. For patients with trending reduced platelets or thrombocytopenia, educate patient and caregiver regarding risks and strategies to prevent falls. There's an increased risk of spontaneous bleeding resulting from a fall. Monitor for fatigue during physical therapy intervention and educate regarding the interval training and energy conservation. Patient will have easy fatigability, so we need to consider load of exercise and period of rest and exercise. Consider using Borg or rate of perceived exertion scale to ask the patient, or dyspnea scale, in addition to vital sign monitoring with activity progression and symptom presentation. If you are trying to increase the load of exercise, and patient will let you know if this exercise load is okay or the patient feels exhausted or tired. Use caution during neurogenic bowel or bladder programs, especially S4 and S5 testing, spinal cord injury or tumors, and rectal examination, as patients may be at increased risk for bleeding. Okay. Discuss with the interprofessional team risk versus benefit if planning to utilize dry needling, given patients with thrombocytopenia are at increased risk for bleeding. Refer to the recommendation by the National Hemophilia Foundation's physical therapy guidelines when working with persons with bleeding and clotting disorders. For patients with tendency of increased RBCs, erythrocytosis, monitor for fatigue during physical therapy intervention and educate regarding interval training and energy conservation. Consider using the Borg or rate of perceived exertion scale or dyspnea scale, in addition to vital signs monitoring with activity progression and symptom progression. A screen for venous thromboembolism using patient diagnosis specific evidence tool like Wells criteria or other tests. Monitor of signs and symptoms of venous thromboembolism and consider referral to a medical provider as appropriate. Refer to a coagulation test and assays. For patient, that's why we do screening, and screening we will be talking about in our lecture this week for hematologic disorder. And if I spot that there might be an abnormality after my screening, I might need to refer the patient back to a physician for further investigation or treatment. For patients with trending reduced RBCs or anemia, monitor vital signs and cardiac rhythm during physical therapy intervention. If there is any arrhythmia or any changes in vital signs, monitor for fatigue during physical therapy intervention and reduce and educate regarding interval training and energy conservation. Consider using the Borg scale to check with the patient with activity progression and symptom. Monitor for leg cramps during physical therapy intervention. Assess and monitor for cognitive impairment due to increased risk for altered mental status. Consider referral for other providers are appropriate. As appropriate, provide fall prevention screening and intervention as needed due to increased fall risk. For patients with reduced RBCs or anemia, monitor for signs and symptoms of orthostatic hypotension during positional changes and throughout the physical therapy intervention. Discuss concerns for orthostatic hypotension, especially during transfer and bed mobility and so on, with interprofessional team if noted during assessment or intervention. Monitor for orthostatic hypotension, educate patient and caregiver on recognizing symptoms, avoiding quick postural changes. Patient is in smile-like position and all of a sudden you ask the patient to stand. This is not right. You need to change the patient position and to sitting, for example, and see if there are any signs of orthostatic hypotension before the next step from movement from sitting to standing. And monitoring blood pressure in the presence of orthostatic or dizziness. I might, check blood pressure during standing and sitting and see if there are any changes in numbers. For patients with trending increase in hemoglobin or polycythemia, monitor vital signs and cardiac rhythm during physical therapy intervention. Provide fall prevention screening and the intervention as needed due to increased fall risk. Implement activity pacing strategies to reduce the load and prevent undue stress on the cardiovascular system. Okay. For patients with trending reduction in hemoglobin or anemia, because hemoglobin, as I said, is responsible for carrying oxygen, collaborate with the interprofessional team regarding risk versus benefit and the need for timing of transfusion, blood transfusion before mobilization. Assess and monitor all vital signs, especially oxygen saturation, to predict tissue perfusion. Oxygen saturation may not accurately represent the physiologic state in patients with severe anemia. Monitor patients with pre-existing cerebrovascular or cardiac or renal conditions for ineffective tissue perfusion, like discoloration, changing color, poor peripheral pulses, decreased temperature, and angina related to decreased hemoglobin levels. Provide fall prevention screening and intervention as needed due to increased fall risk. Monitor for orthostatic hypotension. Educate patient or caregiver on recognizing symptoms, avoiding quick postural changes, and monitoring blood pressure in the presence of orthostasis or dizziness. Implement activity pacing strategies to reduce the load and prevent undue stress on the cardiovascular system. Monitor for fatigue during physical therapy intervention and educate regarding interval training and energy conservation. Consider using the Borg or rate of perceived exertion scale or dyspnea scale in addition to vital signs monitoring with activity, progression, or symptom presentation. For patients with trending reduced hemoglobin or anemia, also there are some additional pediatric considerations. Monitor for signs and symptoms of anemia in premature and low birth weight infants. Monitor for signs and symptoms for developmental delay in infant or child with anemia. For patients with trending increase in hematocrit, like in cases of polycythemia, screen for venous thromboembolism using the patient diagnosis specific evidence-based tool. Why? Due to increased risk with elevated levels. Monitor of signs and symptoms and consider referral to a medical provider as appropriate. Refer to coagulation test and assay. For patients with trending reduced hematocrit, like in anemia, assess and monitor all vital signs, especially oxygen saturation, to predict tissue perfusion. And as we just said, that oxygen saturation may not accurately represent the physiologic state in patients with severe anemia. Provide fall prevention screening and intervention as needed due to increased fall risk. monitor for orthostatic hypotension, educate patient caregiver on recognizing symptoms, avoiding quick postural changes, and monitor blood pressure in the presence of orthostasis or dizziness, monitor cardiac rhythm and signs and symptoms of decreased activity tolerance during physical activity intervention, monitor patients with pre-existing cerebrovascular, cardiac, or renal conditions for ineffective tissue perfusion, like discoloration, weak peripheral pulses, decreased temperature, and angina related to decreased hematocrit levels. Let's go to coagulation test and assay. So plasma D dimer, should be below 250 nanogram per milliliter, or anti-factor, this is factor 10, of the coagulation cascade, and activated partial thromboplastin time, which this is BT, or prothrombin time. This is BTT, I'm sorry, BTT. And the BTT, they use it as a monitor for the intrinsic factors in the coagulation cascade. Like I said, this is a long pathway, factor 12, factor 11, factor 9, factor 8, and so on. And prothrombin time is used for monitoring of the extrinsic pathway of the coagulation cascade, which is the shorter one, like factor 7, factor 5, and factor 2. And yeah, so why we see these are especially for the NPTE, or the National Physical Therapy and License exams. You might see some questions related to these factors, because there are physical therapy clinical implications, like if you have high numbers or low numbers, and there is increased risk of bleeding or any disorders, would you do exercise or not? So risk versus benefits. There are anti-factor 10 assay, activated partial thromboplastin time, prothrombin time, which is a PT, this is a BTT, and this is BT, and the international normalized ratio. International normalized ratio, it is a new measure for blood coagulation, and they use it more now than prothrombin time or the BT. Elevated levels will be associated with increased bleeding tendency, bruising, oozing from wounds, and mucosal bleeding. And there are some physical therapy clinical implications. Due to the increased risk of bleeding, so we need to provide fall prevention screening and intervention as needed due to increased risk of injury with falls. Apply prolonged pressure to the site if bleeding happens or occurs. Examine skin for bruising, petechiae, or blood in the urine, hematuria, or bleeding of the skin. Bruising may result from a blood pressure cuff or other medical devices. These patients have easy susceptibility to bruising. Like I'm giving resistance to the patient, and I am, resisting by my hand. And after that, next time I will see some bruising of the skin. The patient, hit the table and during walking or anything. And what next? Bruising. Using blood pressure cuff and increase blood pressure or compression. Why? Because these patients have high risk of bleeding. Some patients, they are taking blood thinners, and this could also lead to easy bleeding. Monitor for changes in neurological condition due to increased risk of intracranial hemorrhage or bleeding. Educate the patient that falls or contact sports may increase trauma-induced bleeding risk. Collaborate with the interprofessional team if levels are outside the therapeutic range to determine safe exercise prescription and intensity of activity. Thanks so much for listening for this long lecture. I have tried to go quick as much as I can and to explain these important concepts in hematology for physical therapists and for indifferential diagnosis. Thank you, and I will see you soon in another lecture.